Welcome to Everything Health, produced by the A. Philip Randolph Institute. Tonight's segment is sponsored by Kaiser Permanente, one of labor's premier healthcare providers. This is a conversation about health and healthcare in America. Tonight's segment will be hosted by Cleola Brown, president of the A. Philip Randolph Institute. So sit back and enjoy as together we explore everything health. And at any time during the conversation, you may post a question by using the Q&A feature located at the bottom of the Zoom application. And your question may be featured during our Q&A segment later in the show. Once again, thank you for joining us this evening as we start the show.
Good evening, APRI family and friends. Thank you for joining us again, for those who have joined us in the past. And if this is your first time, sit back, take it easy, because you're in for a real treat. Previous presentations have addressed the devastating impact of COVID and the issues of health equity and health disparities from the viewpoint of our health systems. And we've also touched on how folks' thinking on racial equity has evolved during the pandemic. Of course, disparities in healthcare has always been at the top of the APRI agenda, and there's so many factors for that. Our guests this evening come to us through Kaiser Permanente, one of labor's most supportive and trusted partners, with whom we have collaborated on several projects for more than a decade. Dr. Deb Friesen is a physician advisor in customer clinical solutions with over 30 years of experience in the medical field. Dr. Nicole Stetler is a clinical trauma professional and holds certifications in community and organizational disaster mental health. We're delighted to welcome both of them and look forward to hearing their perspectives on the relationships between physical health, mental health, and overall community health. Now, we want to remind our audience that you can place your questions in the Q&A box if you have them at any point during the presentation. Please provide your name and where you're from in the Q&A box or the chat box. So, Dr. Friesen, Dr. Stetler, you have our undivided attention. APRI family, give them a good virtual hand. Thank you.
Thank you so much, Fred. It's really a delight to be with you all and really an honor to join you for this conversation. First of all, I think I speak on behalf of Nicole when I say, please, for the remainder of this, would you use our first names? Deb and Nicole is just fine with us going forward. So would just like to open the invitation there. I think that I'll start first with just maybe teeing up Nicole with a question, which is, your specialty, Nicole, really is mental health, getting the message out to employers, employer groups, which includes unions, of course. Can you tell us about some of the trends that you saw in mental health through the pandemic and the effects that we saw in our care delivery system?
Sure. And I want to echo, Deb, what you just said. Thanks so much for having us. It's really a privilege to be here, and always a privilege for me to be talking about and working in the mental health and addiction space. I think kind of across the board and across the country, what we saw early on in the pandemic was some kind of drawing back of people looking for services. So, and I'm talking about those who might already have been reaching out, or, it's oftentimes something people will put on the back burner if they have an emotional well-being issue or maybe a substance abuse issue. The concern over health, the just kind of nuts and bolts of survival, offices closing down, food, the toilet paper shortage. I mean, those were the things that we were kind of, really focused on. Those were our basic kind of bread and butter medical and health concerns. And so a lot of addiction and mental health care went on the back burner. So there was a lull then in some of where we saw people really not engaging in care, but knew that they were out there and concerned about, does this mean then that there would be a wave at some point of people kind of reestablishing care? Maybe they've gotten worse. There are new diagnoses or new conditions, propping up. And that did end up being kind of what we saw, where towards the end, probably I want to say towards kind of the end of the summer, middle of the summer last year, I think in every of the regions that Kaiser Permanente is in, we started to see increases in people calling in and asking for care at various levels of acuity, meaning that there were those who had been able to kind of manage a chronic condition like depression or anxiety or alcoholism, but needed to get back into care. They couldn't, wait any longer. And then there were those who maybe had been in recovery for a while that then relapsed based on just all of the things that individuals, communities, businesses, that everybody was going through. I think besides the pandemic, the isolation and anxiety and kind of collective trauma of all of the protests and all of those community conversations also really, I think to some extent underscored some of the disconnect and health equity issues that we've been talking about for years, and then now seeing it really play out under very pressurized circumstances made for not only a lot of volume, so a lot of people calling in and wanting support and mental health care, addiction medicine care, but also a very kind of a pretty high acuity level. By the time people were coming in for care, they were in pretty bad shape. So
yeah, mental health really is a spectrum. And I think even people who normally weren't having, anything but maybe mild symptoms, really, we all shifted, right? With anxiety, depression, insomnia. And, there were jokes. And even before the pandemic, it's wine o'clock for all the moms at home kind of thing. Well, all of a sudden we're all at home, and one of the things that we saw was alcohol sales actually continue to rise. And when you got takeout, you could now get takeout margaritas, and it sounds like it's a really good thing, right? But on the other hand, when that starts to become, your coping mechanism, then we see it become maladaptive instead of kind of a temporary or somewhat adaptive mechanism. You brought up social unrest. Can you speak a little bit around, the stigma of asking for help? We've done a lot at KP around that already to kind of reduce that stigma with information and campaigns. But I still believe that there is a significant stigma about reaching out in the African American community. Did we see that in our experience as well?
Yeah, it's a great question. And probably one of the greater challenges of health equity is mental health and addiction with communities, whether communities of color, LGBTQ, across the board, any communities that are marginalized to the extent that a person expects the healthcare system not to show up, no matter what anybody is telling me it's going to do. I have the experience, or I have the presumption that that's not really for me. That's not built for me. It's not built by people who understand me. And so there is a general hesitancy to engage, or to engage begrudgingly. That's kind of built into the system. I think we do a lot of work at Kaiser Permanente around cultural competency, culturally responsive engagement, to try to outreach and engage with, yes, communities, but also the individual level person who is hesitant to seek care. And there are millions of reasons why that's true for them. And so we try to really attend to that. I think, and then you add on the stigma and the associations and a lot of the misunderstanding around mental health and addiction. And that in in a large number of communities, there's an additional kind of pretty harsh perspective of what that means in terms of weakness, or, my community is already looked down upon. Now you're going to bring more, shame or stigma to us as a community if you're going to be open about your healthcare issues, or, as it relates to mental health and addiction. And I think we've also seen that over time in other outbreaks, in other, in different communities where, if you think of the HIV/AIDS crisis, that was another space where it was really, for so long, we didn't want to, people in the community, the gay community, did not want to talk about it. This is bringing the kind of attention we don't need. And at the same time, there were really very real, very objective health issues that were both individual and community based. And so it's really dangerous, I think, stigma generally, but also in the way that it has an impact on medical care. So with addiction, if I feel that kind of isolation from the systems that would support me in my addiction because of my membership in a marginalized community, then that cascades into other healthcare. I'm not going to be as quick to get care for diabetes, for cardiovascular disease, for you name it. There's going to be a delay. And part of that is because I don't want to be sitting across from you, Dr. Deb, and having you ask me questions about why does it, what's my alcohol use been, or what's my recovery been? And so it really sets up a lot of barriers to getting, the right kind of care in a timely fashion that's as helpful as can be and as effective really as can be.
And this is a question for both of you.
Mm-hmm.
There's appears to have been an increase in suicides in certain communities. Could you speak to that? And in the city where I live, there's also been an increase in homicides.
Mm-hmm.
Newspapers and news media indicate that there's an uptick in domestic violence. Could you speak to those issues?
Sure. Deb, is there anyone you want to start off with that? I have some things to add there, but.
Well, I'm just so appreciative of the question, actually, Fred, and just want to share, if any of you know me, I actually lost a brother to suicide many years ago. And one of the things that got me through the grief of that was reading when someone said, when someone jumps from a building, we can see the flames at their back. And so we understand sometimes why that happens. And with suicide, we just don't understand what those flames at their back really look like. And this has been such a communal experience of so much that has weighed upon people, where they're not thinking correctly. The biology of the brain actually changes under stress, under duress. We are actually not thinking clearly. So when people say, "What were you thinking?" they really weren't. And so I think there's a general misunderstanding of depression and suicide. They can be two different things at the same time. And then, of course, we approach it very differently as far as attempts with men and women. Women tend to choose methods, as it were, that are not as lethal. And it's not just for drama. It's not just a cry for help. It's just a choice. Whereas men choose, unfortunately, more lethal methods. And so they complete a suicide more often as well. But again, a lot of this comes out in our coping mechanisms. You brought up domestic violence. This is also something that we saw increase significantly through the pandemic. And people didn't have options. They didn't have a place to go. They might not have had financial options or money. They might have lost their job. They've got children at home that they need to raise. They couldn't travel. And so all of those things, we really anticipated a much higher rate of suicide, or worried about that through the pandemic than we ended up seeing. But it was real and it was there at the same time. Nicole, I'm going to let you jump in.
Yeah, all of those things are, I think the distinction you made too, Deb, that's really important, and a really common misunderstanding is that mental illness and and especially depression, go hand in hand in a like a causal relationship to violence and suicide, whether it's attempt or more lethal means. And they're very different occurrences. Suicide is oftentimes a very impulsive act, a very kind of helpless and hopeless act, and can have more to do with what I've experienced today than what I've experienced the rest of the years of my life. So it really depends on the situation. That said, though, I think there is, and when we talk about violence kind of generally, there's also a coping, when there's violence against others, there's a kind of I want to say maladaptive, but it's not exactly the best word to use, but kind of a coping strategy in just frustration and the helplessness and hopelessness and anger of, I am stuck, whether it's financially, educationally, I'm stuck in a violent home. I can't, there's nothing else I can do. And the frustration of that, I think at some point, if I haven't learned other ways to, be empowered or feel empowered or cope with some of that, that anger or frustration. And I think you see this in a lot of, again, marginalized communities, when then we're all isolated from each other, and I might be able to go talk to you, Fred, or to you, Deb, in person, and we have regular kind of exchanges. We get to let a lot of that tension that builds for anybody. That's where those things kind of let off a little bit. And when you don't even have that, because people aren't available to you anymore when we're all under quarantine, I think, people run out of options to cope with what is really tremendous stress, and then not feeling like, something like the health system is really there to protect me or help me. Whether we do that, consciously or not, almost doesn't matter. My perception is the health system isn't equitable and isn't going to be there when I need it in the way that I need it. So I think that's what I'd say about that.
There's some indicators that family members could look for.
Yeah, Deb, I'd love to get your take on this too. I think one of the biggest things is a really kind of sharp behavior change, and oftentimes we'll think of like, oh my gosh, yeah, they were really sad all of a sudden in the last week or so, when in fact it can also be the opposite for somebody who has kind of decided and been planful about a suicide attempt. That's a lot of relief for some people to finally kind of make that decision. I feel lighter. I'm, objectively kind of happier. I've decided I'm going to take control of the pain that I'm feeling and be done with this.
And it's ironic, right? I mean, it's like
very much,
how is it that they seemed better? So how could they have done that?
And
or
you hear that, yeah.
Yeah, and you hear that from those left behind. But there is that sense of relief of, I have a plan. I know that whenever I'm stressed and I make a plan, I feel better. And so it's just that change that happens. Another thing that comes up is saying goodbye. People they like to even have some closure as they complete their own plan. And so if someone reaches out to you and it just seems a little off, or they are saying goodbye, or I want you to have this. Sometimes it's even possession that they want you to hold or have as a memory of them. And they start, oh, I just wanted you to have this. That's not normal. That's not right. And so let that be a clue, and raise the hair on the back of your neck to say, what's going on? And the other thing that can really help is to just ask. We hesitate to do that. And again, it's part of the stigma, but geez, Nicole, I've noticed this, and you wanted to give me this something. I have to ask, are you contemplating suicide? Are you thinking of harming yourself in some way?
It is important to use the actual words. To not use a euphemism, or, are you thinking of offing yourself? Use the term suicide, ask directly. Yes, it's really uncomfortable, but no more uncomfortable than if there was something that ultimately happens and you didn't ask. I think the other thing that is a myth too that's really important to call out is you cannot make someone suicidal by asking them. You can't put the idea in their head, you know, they were fine until you asked if they were suicidal, and then they you know, made an attempt. That's not how suicidality works. So don't be afraid of asking questions, and you know, just you're doing that because you care and your gut says something's going on. And even if it isn't, hopefully the person you're asking is, you know, feels cared for, that you would, you know, even try to ask. So.
And I'll pile on just a little bit more, Nicole, which is you talked about kind of the impulsivity of that. And there's also a specificity. When people make a plan, it's often a very specific plan. And again, ask if they have a plan. If it involves something like a gun, make sure that's removed. But as an example, some people they're going to jump off a bridge. Well, if something happens as they're driving to the bridge and there's a detour and they can't get to that bridge, they don't go, oh, change of plans, I'll go find another bridge. Right. Their whole plan was specific to this bridge and it got interrupted. So if we can interrupt their plan, yeah. So if we can interrupt that plan, then there's more time that we have opened up, and there's space that we've opened up to have a different conversation while interrupting that plan, by not having the gun in the house, by not having the ability to get in the car, etc.
Yeah, that was a good question.
You know, recently in the past, month, we've had Sister Osaka, the tennis player, drop out of Wimbledon competition. A couple of days ago, Simone Biles dropped out of the team gymnastics competition, and Michael Phelps has shared that he suffered from depression and anxiety, the champion swimmer. So it's probably helpful that these very high profile people are now talking about the impact of mental illness and having to deal with it.
Yeah, I could not agree more with that. It's really huge to see, you know, people that, you know, anybody might look up to, or somebody who looks like me, who's famous, or just somebody who I can, you know, easily kind of get behind or respect. Just that they're willing to raise their hand and identify with those things, and then also talk about that it's something they work on, but that also it's something they are paying attention to, in the same way that, in this case, we're talking about athletes. So in the same way that they train for their athletic endeavors, they're in keeping their you know, bodily health and their skills intact. That includes your brain and your mind, and you know, avoiding injury and illness in that big organ too. So I could not agree with you more, Fred, on that. I think it's so important. The more that we normalize the conversation about emotional well-being, you know, mental illness, addiction, I think I can't imagine really anything bad about that. No downside.
So I think you also do quite a bit of work with the LGBTQ plus and the transgender community. Have we seen any upticks in illnesses in that population?
I'm not sure if we could narrow it down to that. Deb, you might know that. I think any community where the social aspect and social supports was taken away. So if it's my religious community, but I haven't been able to go to church, no matter what my identification is, or ethnicity or language, those are my peeps. That's where I go on a weekly basis to get what I need, which includes you know, identity and social support. And I think for the younger of any of our communities, the teenagers, young adults, there are significant social developmental things happening for any of us in that age range that require social interaction and me building my sense of self off of interactions with you and in person or with my community. And if those things get shut down and I'm already part of a community, whether it's LGBTQ or whomever, where I'm already feeling isolated, and then the rest of my social connections go away, that's pretty dangerous. And I think that's where we've seen, for especially teenagers and young adults, an increase in depression, anxiety, acute substance abuse, especially around alcohol. I don't know, Deb, if you've seen anything else in that space.
Not specifically as it relates to COVID, but all the things that you just said are true. And again, if you increase that isolation, we know that that population, again, really starting in adolescence when it comes to identity, if they're not in an affirming environment, that's a stress. And then you take away their ability to be with other people, to have that social support. We know that there's more use and abuse of substances, alcohol, other things included. They're the biggest proportion of runaways a lot of times, or having to sell their bodies in order to actually have money to live. They're more prone to be victims of violence, either with an intimate or in stranger violence. Their rates of suicide attempts and completion are higher. And so you take all of that as a baseline, and then you add a pandemic and no ability to get out. The stress, the anxiety, the depression, all of that increases dramatically. The great thing is that we still had the ability to connect. Virtual, it's not the same as seeing people in person at all. But just the young people, they found ways. They get on their Discord servers. They can text on their phones. They don't talk on them, but they text on them, right? They can actually, have their, my kids had movie parties where they were all watching the same movie from their bedrooms on their tablets. So I think that there was some kind of response and relief. And then along with that is the ability to actually deliver care virtually as well, and providing access to mental health in the virtual space. I think that was a boon. And there's much more to do, but at least people were not left with nothing. They still were left with an ability to connect with each other and a therapist, a counselor, their doctor, to have an evaluation, to have a screening around anxiety, depression, drugs of use and abuse. Women having babies, we screened. We were able to screen for domestic violence when we would have those interactions with them. So care continued, it just looked very different.
Yeah,
Okay,
and
so
thank you to sorry, Fred, I was just going to say thank you to, I think, Tony Lewis. That's a great resource you put in the chat. So if anybody has a chance to look in that chat, that's really a great place to check out.
okay.
Sorry, Fred, I stepped on you.
No, that was fine. You stepped on Jan. So, parting words of wisdom to help us navigate through this. I know one of the things that's very troubling with me, because for almost a year, I felt like I was quarantining for a whole year, but now stuff seemed to be loosening up. And now we have the Delta variant of COVID. And I really get mad when I see people without a mask in the grocery store. I walk away, make sure that I social distance from them. So any words on that? Had to deal with the uptick in COVID.
I'll let you answer that one, Deb, because I'm over here going, I know.
I feel your pain as well,
Yeah.
Fred. As far as keeping healthy, you're doing the right thing, wearing a mask. Delta is real. The CDC, I think, is right to recommend that. But we can only do what we can do. And so I think that a lot of this is a mindset, right? It's There's people I love who have bad behaviors, even separate from COVID-19. And we can do what we can do to influence. And a lot of what we do is just living our lives in a way that we think is right. And being an example as much as we can to those we love who love us, and to our greater community at large. One thing that doesn't change hearts and minds is shame, anger, and so I think it's just continuing to be open-hearted as much as we can, to be empathic. But our greatest responsibility is to live another day so that we can do the good work that we're here to do. And so, so keep yourself safe, keep yourself healthy, get enough sleep, eat your vegetables, reach out to people.
The basics.
Yeah, people, reach out to people who love you, and that you love, and have boundaries. It's so blurred as we're all working from home right now. We are not machines. And so have those boundaries and take time to rest and rejuvenate and connect.
Okay. Jan, do we have any questions in Q&A?
Yes, there are a couple of questions, or actually some comments in the chat from Jeffrey Johnson in our Baltimore chapter. He put a question in quite close to the comments about seeing a therapist or a person who could help with some mental or depression or other issues. And he wants to know, how do you get more sessions built in? You're in bad shape and you get 3 or 4 sessions when you need a lot more than that. How do we get well? That's his overall question.
Yeah, let me see if I can answer that. So speaking outside of the Kaiser system, right? So I think that's generally true, Mr. Johnson, that any of us would be treated for the acuity of the symptoms that we have in that day, in that moment. That said, in mental health care, not as much in addiction, but certainly in psychiatry and mental health, there is the subjective distress of something as well. So there's always got to be a balance of objectively, what is my doctor kind of getting from me, and how long does he or she think I need to be seeing somebody in outpatient care, a therapist, and how frequently that needs to happen. But there's also what is my own just kind of level of distress around it, and then, is it keeping me from work? Am I not sleeping well? Am I not eating well? All those other kind of functional things that can get really kind of messed up when we're not feeling well and suffering from something that is mental illness related. So that's kind of the longer answer, but the other part is oftentimes when we're working, there are a number of different programs that you have access to. There's employee assistance program, there's your health plan, there are community clinics. There are generally, the other place that I oftentimes will direct people is to local universities or colleges who have counseling programs, who have interns who are trained and more than able and competent to meet with you, either in an individual level or a group level. One of the biggest problems, that's a real concern we have across the mental health care industry and across the country, is there are fewer and fewer providers. We were already, before COVID, really struggling with just a real kind of dearth of psychologists, psychiatrists, marriage and family therapists, LCSWs, you name it, across this kind of that mental health care spectrum. Fewer and fewer trained folks available to see people, and then the volume increase with COVID, and the need for care increase with COVID and the pandemic and quarantine. And I think that will probably continue. So what that ends up looking like is, 5 years ago, I might have had mild depression and I could see somebody every week for as long as I needed to. But now what that looks like is, if it's mild, the person who is maybe a lot sicker than me and right now is going to get that appointment before I do. And that really is, again, about the volume of people who are needing care, and it's kind of that supply and demand thing, right? There are just not enough therapists to treat everybody that wants it and needs it. So that's not a great answer to your question. I wish I had a better answer that was more simple and satisfactory, but that's what's happening right now.
Thank you. Another question from Elizabeth Serban. Can you touch on correlation between mental and physical health? Poor mental health can be a risk factor for chronic physical conditions. Is it possible that it may not be chronic? It can start with minor aches and pains, headaches, ulcer.
I'll start, Nicole. Thanks for that great question. There's such a correlation between physical and mental health. And sometimes it's just even starting with a poor night's sleep because you can't let go of something. And then the next day you're sleep deprived. And again, your brain chemistry, your neurology, all of that can change with these physical conditions that we have. Or maybe you're in a great space environmentally and physically, but you add anxiety or depression, or maybe even addiction to that mix. Again, brain changes happen. It can manifest in the body. I can't tell you how many times I've had people come in and say, you know what, doc, there's something wrong with me. I'm just not sleeping at night. My back hurts. I can't focus on anything. And I've been having palpitations. And I run through and I try to help them decipher what it could be. And I say, invariably they want me to diagnose them with a thyroid problem or say that they need more iron. And a lot of times where we end up with all of those physical symptoms is I'll do a screening for depression and anxiety. And it will be positive. And well, are you telling me that my back hurts because I'm depressed? Actually, yes.
Yeah.
And so there's a very deep connection between those two things. And the good news is that a lot of times helping one will actually help the other. And we really are a body mind. We're not a body, we're not a mind. It's the mind in the body. And so we have to look holistically at this person that we are, this person in front of us, in order to get to a true state of health.
Yeah, two quick things I would add, and this is such a good question. There are also, we are more prone to injuries. So, and that can be because of a chronic, because of substance abuse, of course, but a chronic or acute psychiatric condition or emotional well-being, mental illness issue, where if I don't sleep for a while and then I go to work, I'm going to be much more prone, depending on my job, to make errors, to have an injury on site, get in a car accident, just, trip over a door threshold. It can be something even as simple as that. I'm going to be much more prone to those kinds of accidents. And the other thing is, when we were talking about stigma a little earlier, oftentimes it is so much more acceptable to me and my family or my community if I've grown up in a space where everything is around mental health is stigmatized. It's so much more acceptable if I've got a physical illness, I've got an ulcer, I've got, high cholesterol, whatever it is. Cardiovascular is a pretty, unfortunately, kind of a popular one in that space too. And it's not exactly depression and me not taking care of myself and those things happen. It is literally, psyche and the unconscious, part of you. I can't get help this way. So body, you need to kind of be the one that's raising the red flag and getting care because I'm not doing well. So stigma can have a lot to do with how it manifests in the body.
Okay, and then we also have a question from Tamika Mason dealing with our younger family members. When preschool or elementary school age children make comments or jokes about harming themselves, is this something to take serious regarding their emotional state, or more likely just a reflection of what they've observed in the media?
That is a really good question. I think there are a couple of approaches. So one is, yes, take it seriously is the thing about it. Yeah. But part of that is knowing that when you take that seriously, you are also modeling and communicating that that's a very serious thing to say, where that's not something we joke about. It's not, we don't be flip about it. But if this is really serious and you are really feeling poorly, then I'm going to get you the help that you need to have. Sometimes kids will, and I don't want to minimize when a kid will say something like that, but that's the only way they know how to kind of say help. I don't feel well. And of course, if you press them on it, they would say, no, 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 of course I'm not going to, I'm not actually going to do that. But that's really the only place they know to go, or it's something they've heard. But it is really, so it's important to respond, right? And not to blow off, but know that part of your response is also, having them take that kind of phrasing really seriously, and sets them up, I think, for being able to identify and talk about what they are experiencing and what they need in ways that are appropriate. And also knowing that, yeah, you can push the nuclear button too if you're really feeling that bad, and somebody's going to step in and care for you when that happens. So I don't know, Deb, if there's anything else you would add to that for that age group, but it's
No,
also
just
always
again,
really hard.
yeah, and again, I just want to emphasize that they're using the tools that they have.
Right.
Their brains aren't developed. They may be struggling with bullying, with isolation, with
Could
loneliness,
really be about anything. Yeah.
so many things, pressure. And so that's the tool that they have, and they're going to use that maybe just to get your attention and start the conversation.
Right.
Okay, I don't see any more questions or comments, but I do want to pass on what Dr. Tony Lewis put in regards to a couple of resources. Folks might want to jot it down.
Right.
One of them is the National Black Justice Coalition. Their website is nbjc.org. And she's indicating that, of course, that's one of the leading national civil rights organizations dedicated to the empowerment of Black, lesbian, gay, bisexual, transgender, queer, and same gender loving people, including people living with HIV/AIDS. They also, in that same website, have a subsection under stress, trauma, and healing for trauma and healing work. So I think that would help to address some of the earlier questions if folks write that one down. And I think that is the only thing else. Oh, I'm sorry, there's one
Got
more.
another one at the bottom. Yeah.
Yeah, the other one is under, this is therapists that specialized in working with the issues and aspirations of Black and Brown communities and community resources. It's Baltimore-based. A person by the name of Shauna Murray Brown leads it. And that one is called, one moment. The website is therapythatliberates.com. therapythatliberates.com. And I'm not sure how we can extract it from the chat, but I can check with Dave or some of the others. Maybe we can do that and put it into the area where we have the review of the site under resources, if that would work. We'll try to get that done, but if not, hopefully you can write it down. That's all I have, Fred.
Fred, you're muted.
You're muted, Fred. Okay.
How's that?
There you are.
That's great.
Okay, so again, I want to thank Deb and Nicole for being
Thank
on
you.
the program this evening. And a big shout out to Kaiser Permanente, its leadership, its staff. This is our final segment sponsored by Kaiser. So we really appreciate Kaiser Permanente, Dr. Copeland, Dr. Ruth Williams, Chris Blast, David Cooper, all the people who have worked with us over the past couple months. We really appreciate all of your help in making this possible. And next month, we will be talking about, now that we know a lot about what some of the problems are, what some of the inequities are, how do you fix it? And so we will be approaching it from a legislative perspective, because in the final analysis, whether you're talking about to wear a mask or not wear a mask, to get vaccines or not, they end up being legislative questions. Cities, state governments make policies and laws to deal with those kind of things, and they put money into funding it. So we want to have those discussions in the coming weeks. But Nicole and Deb, thank y'all so much. I know that we went a little bit over time, but that was y'all's fault because the information the information was so
Glad
good,
to.
and the chat filled up and the questions filled up. But thank you so much,
Yeah, thank you very much.
and look forward to working with y'all again.
Yeah, I
Thank
hope
you.
so.
Okay.
Thanks for letting us be here. Appreciate it. Have a great night.
Take care,
All
y'all.
right. Thank you.